Good afternoon, all. ITech India welcomes all the participants for today's regional distance learning seminar series. Today's topic is management of HIV-exposed infants and children, and management of newly diagnosed HIV infection in children, including ART initiation. And today's speaker is Dr. Sanjeeva sir. Is the program director with Pediatric Centers of Excellence, IGICH, Bangalore. We welcome you, sir, for today's session and request you to start the session.
Thank you. Today we are discussing management of HIV-exposed infant and children and management of newly diagnosed HIV infection. I think we all know this topic, and this is just refreshing our knowledge and updating ourselves with the new guidelines. And okay, so these are the components which I'm going to discuss today. Introducing the topic, then care of HIV-exposed infant and children, infant prophylaxis and immunization and vitamin A supplementation, growth and development assessment, determining the clinical and immunological staging, evaluation of an adolescent living with HIV, ALHIV, and antiretroviral therapy for children. What are the drugs available, when to start, how to start, which drug to start, so all those things. So management of an HIV-exposed infant. We all know what do you mean by HIV-exposed infant or children. It is born to mothers who are infected with HIV. So these children are called as HIV-exposed infant. Till we confirm or exclude HIV infection in these children. So once we confirm HIV infection, these children will be called as HIV-infected children. If you exclude HIV infection reliably in these children, then we call these children as HIV-affected children. So we have three definitions: HIV-exposed children or infants. These are born to HIV-positive mother, but we don't know what is their status. So once we determine their status, they will become either HIV-infected or HIV-affected children. So now some data. Currently, it is estimated that, not estimated, more or less, we have around 81,000 and odd children who are living with HIV. This is the data from our NACO. And this accounts for 3.5% of our total HIV population in India. And when you look at our new HIV infection in India, every year annual infection, 10% of the total infection is among children. Children means less than 15 years of age. So what we have achieved is, over a period of last 1.5 decade, this new infection rate has declined by 55%. But still we have got a long way to go. So this is again summarizing the same data. HIV related deaths among children is around, there are around 3,500 children every year are dying because of HIV infection in our country. Now, what is the target and what we have achieved? So as I said, in the year 2010, the mother to child transmission was around 40%. Now it has come down to 27% in 2020, thanks to our PPTCT regimen and various changes there, increased coverage. So we have significantly decreased the infection rate. Now our target is to achieve 5% or less than that. So we all know this is achievable, because in children, more than 90% of the HIV infection happens through mother to child transmission. So we know the source of transmission. So if we can address that source, definitely we can reduce the transmission. So to achieve this, so in India, we have estimated around 30 million pregnancies every year. And it is estimated that around 20,000 of these pregnancies happens in women with HIV infection. And there are various bottlenecks, but still this is the data what we have. And infants who are born to these 20,000 HIV infected women are at risk of acquiring HIV infection. And our focus is on these 20,000 and odd children, HIV infected mother, so that we can reduce the transmission rate to less than 5%. So we all know what are the interventions available. Currently, what we are using is 3 antiretroviral therapy with breastfeeding. With this, we could be able to achieve around 2% of risk of transmission. And rest of the things we are not following now. So we can focus on the three ARV therapy, that is ART, with breastfeeding, it's around 2% HIV risk. Now, why these children are vulnerable group? Why these HIV exposed infants are vulnerable? We all understand that HIV infected children are vulnerable, definitely because of low immunity. But even those children who are not infected, they are also vulnerable population. Why so? It's because on three count. One is they are increased risk of various childhood diseases. They have got an adverse social and economic factors, and the progression of the disease is rapid in them. So these children are increased risk of developing malnutrition because their energy demand is more. They will have, as a result of that, they will have growth failure. They can have developmental delay because of in utero and perinatal exposure to the virus, drugs, and other opportunistic infections, and maternal illness. So many things, and they are prone for repeated infectious disease related morbidity. And adverse social and economic factors like poverty, broken families, parental sickness, drug abuse, and stigmatization by the society. And we all know that in children, the HIV infection, the progression is very rapid, especially in first few months of life, and often lead to that. Similarly, other infection also in infancy, the progression is rapid, even if they are not HIV infected also. So we all know, if you don't treat these children who are infected with HIV, 30% of them, more than 30% of them, they succumb to this infection by 1 year of life. And more than 50%, nearly 50% of them, they succumb by 2 years of life. They don't see their second birthday. So it's very important that we need to identify these children as early as possible. And if they are unfortunately, try to prevent the infection. If you can't prevent that, unfortunately, if they are infected, then we better to start treatment as early as possible, so that you can reduce the risk of mortality in these children. Now we have defined what is HIV exposed infant. We have also discussed about their vulnerability for various childhood diseases. So let's see how to care these HIV exposed infant. There are various components of care of these HIV exposed infant. One is immediate care at birth, then infant feeding, ARV prophylaxis, immunization, and HIV vitamin A supplementation, co-trimoxazole prophylaxis, growth and development assessment, early infant diagnosis, and follow-up. So as soon as the child is born to HIV infected mother, you need to wipe the baby's mouth and nostrils as soon as the head is delivered, so that child will not aspirate the maternal vaginal fluid, which may be contaminated with the HIV virus. So then infant should be handled with gloves until all the blood and material secretion are washed off. This is an universal precaution, so that you yourself can be prevented from an occupational hazard. And the most important thing is you need to clamp the cloud as soon as possible, and milking should be avoided. Usually we advise milking in the normal circumstances, so that child will get an extra additional nutrition, but this should be avoided in children who are born to HIV infected mother. And while cutting the cord, you need to cover the cord with a gloved hand and the gauze, because the blood should not splatter, and to prevent occupational hazard. Similarly, initiate feeding within first hour of birth according to the preferred and informed choice. So you would have counseled the mother during pregnancy, and mother would have, and the family would have chosen some options, and we need to start that as soon as the child is born. Now, what are the infant feeding guidelines for children less than 6 months? We all know the breastfeeding and concurrent antiretroviral therapy to the mother, as well as infant prophylaxis. Combination of these two will lead to a greatest chance of HIV-free survival. So breastfeeding provides infants all the required nutrient and immunological factors. So exclusive breastfeeding is advised for in the first 6 months of life for all HIV-exposed infants. And at 6 months of age, we need to start complementary feeding along with continuation of breastfeeding. And information about the alternate feeding options and their advantages and disadvantages to be provided during pregnancy, during antenatal period. And we should always remember that exclusive replacement feeding is not a viable public health strategy in India. These are very rare cases where mother may opt for that, but as usual, as a common practice, as a public health practitioners, we need to always promote and advise on exclusive breastfeeding in these people also. Now, what is the national HIV guidelines, infant feeding guidelines for children or infant less than 6 months? Mother should be motivated to provide exclusive breastfeeding for 6 months of life. Even in normal circumstances also, this is very difficult to achieve unless they are motivated. Most of the time, the families opt for a mixed feeding by around 2 to 3 months of age because of ignorance and lack of proper counseling. So we should always motivate them with every visit. We need to talk to them about the importance of exclusive breastfeeding with respect to the maternal, infant nutrition and immunological advantages, all those things we need to talk. When exclusive breastfeeding is not possible for mothers, they can be reassured that maternal ART reduces the risk of HIV transmission in the context of mixed feeding as well. Sometimes what happens is when there is a accidental mixed feeding, so mother would have given something else apart from breastfeeding, then we tend to tell them talk to them about stopping the breastfeeding. So we need to avoid such type of thing, because we are already giving ART to the mother. ART will make the breast milk safe. So even if there are chances of some accidental mixed feeding, that should not make us to stop breastfeeding in that context, because when the mother is taking ART. So you should always encourage exclusive breastfeeding. If there are accidental mix-up, then also we should not stop breastfeeding. You need to continue breastfeeding there also. In HIV infected mother of a mother and their child is either HIV negative or you don't know the status, then exclusive breastfeeding for the 6 months should be continued. For example, if a baby who is born to HIV positive mother and you do 6 weeks of at 6 weeks EID, at that time you find that this child is HIV negative, then you don't need to shift them to the alternate feeding. You need to continue breastfeeding in those infants also. And you should always introduce appropriate complementary feeding at 6 months, and should continue breastfeeding for 12 to 24 months. Usually we advise up to 24 months. And breastfeeding should only be stopped once a nutritionally adequate and safe diet without breast milk can be provided. Suppose usually we expect this to happen by around 2 years. So exclusive replacement feeding may be considered only in few situations where breastfeeding cannot be done or upon individual mother choice. For example, if mother is very sick or mother is unfortunately died and we don't have a mother to feed, in such situations, or sometimes mother is wants to feed the child with a replacement feeding, we can advise replacement feeding in those situations. But as a norm, exclusive breastfeeding is the recommended feeding choice and is recommended public health strategies to prevent HIV infection and promote the general health and well-being of the child, even in the context of HIV infection in the mother. Now, what are the benefits and risks associated with breastfeeding and replacement feeding? Benefits of breastfeeding is definitely it contains all nutrients for the baby's need in the first 6 months of life. It is easy to digest. It protects from various childhood disorders like diarrhea, pneumonia, and infections. It is readily available, does not require preparations. It helps mother and infant bonding. It helps mother to recover from childbirth early. It protects the mother from getting pregnant again too soon. Whereas the risk of breastfeeding is there is a risk of acquiring HIV infection as long as the baby is on breastfeeding. On the flip side, in the exclusive replacement feeding, there is no risk of HIV transmission through feeding, and other family members may be involved in feeding when the mother need help. So mother will get adequate rest during that time. But the risk with the exclusive replacement feeding is the expense or the cost attached to the alternate feeding source, water, fuel, and additional task of cleaning is there, and babies are at risk of contracting diarrhea, pneumonia, malnutrition, and other childhood illnesses. and mother may be questioned if there is no proper family support. It will be difficult to practice exclusive replacement feeding. And the 6 criteria to assess the exclusive feeding, replacement feeding are: we need to look at whether there is a safe water and sanitations available at the level at the household level. Mother and caregiver can reliably offer to provide the sufficient and sustained replacement feeding. Can they able to afford the cost of this replacement feeding? And is it feasible for them to prepare the frequently enough in a clean manner so that it is safe? And in the 6 months, exclusive replacement feeding can be given. Is it possible for them? And the family is supportive of this practice. And mother and caregiver can access healthcare that offer comprehensive child health care services. Mother should be counseled regarding choosing feeding strategy, and further on choices they make to feed should be respected. So in continued presence of maternal ART, this point to be underlined: mixed feeding is also rendered safe, may be preferred over no breastfeeding at all. For example, in some situation where mother wants to go for a work and mother is on a very good ART and her viral load is completely suppressed, so during that time we can advise mixed feeding also, even if mother wants to give other milk also. So because whatever the advantage of breastfeeding is there, that can be given. So EBF is still recommended during the first 6 months, but practicing mixed feeding is not a reason to stop breastfeeding in presence of an antiretroviral drug. Suppose if your adherence is poor, if viral load is high, the whole the game changes, then you need to be very careful in advising that. So complementary feeding, what are the principles? So introduce complementary feeding at 6 months of life, and along with the breastfeeding. Continued breastfeeding at 6 months, small amount of food, increase the quantity and frequency as the child gets over while maintaining frequent breastfeeding. Gradually increase the food consistency, variety as the infant grows older and adapting to the infant's requirement and ability. Feed a variety of nutrient rich and energy dense food from family pot, and practice responsive feeding, that is active feeding. You involve the child in the feeding, self-feeding and other things. And all breastfeeding should stop only when nutritional adequate safe diet without breast milk is available, and child nutritional status should be regularly assessed. And you need to classify these HIV positive infants or children into 3 groups. One, they are growing well, or they are having poor weight gain, or condition with increased nutritional needs, or severe acute malnutrition, and you need to address their situation accordingly. In addition to age-specific need, these children who are growing appropriately require additional 10%. If they have got any symptoms of HIV, then they need around 20 to 30% extra. If they are having acute severe malnutrition, then they may need around 50 to 100% extra calories over and above their age-specific needs. The next component of HIV care of an HIV-exposed infant is ARV prophylaxis. This is an important component to prevent HIV infection in these children. So to advise HIV ARV prophylaxis, we need to categorize these infants into 2 groups: low risk infants and high risk infant. Low risk infants are infants who are born to HIV infected mother, whose plasma viral load is completely suppressed, less than 1,000 copies, when it is assessed anytime after 32 weeks of pregnancy up to the delivery. So late pregnancy viral load is suppressed, then these infants are categorized as low risk infant. The prophylaxis options is syrup nevirapine is advised, and it is advised up to 6 weeks of life. If nevirapine is contraindicated, then you have to give syrup zidovudine. So when nevirapine is not used when infant is born to HIV-2 confirmed mother, or HIV-1 and 2 combined infection in the mother, or mother has received in the earlier pregnancy nevirapine, or mother is on PI-based ART regimen due to treatment failure. Whereas in high risk infants, who are defined as infant born to HIV positive mother, not on ART, our maternal viral load then could not be able to do a maternal viral load after 32 weeks of pregnancy. Our maternal viral load, when it is done after 32 weeks of pregnancy, shows viral load is not suppressed, or any mother who is newly identified HIV infection within 6 weeks of delivery. So in all these the infants who are called as high risk infants, the options are you need to give a dual prophylaxis, that is nevirapine and zidovudine. So the duration depends on the feeding option. Exclusive breastfeeding, you need to give this prophylaxis up to 6 weeks of age, or in case of replacement feeding, it is up to 6 weeks of age, or 6 weeks of total duration. When zidovudine syrup is not available, then we can give syrup lopinavir, retinavir boosted lopinavir, but it can be used only after 14 days of birth. So in such situation, start with nevirapine for first 14 days and then add syrup retinavir boosted lopinavir after 14 days. Another alternative is you can use zidovudine, lamivudine and nevirapine pediatric formulation with an appropriate dosage, but you have to consult the pCoE or SESAP for these options, various other options like nevirapine, lopinavir, usage of lopinavir, or zidovudine, lamivudine and nevirapine pediatric formulation usage. So the dosage, we all know, depends on the weight of the child. Less than, between 2 to 2.5 kgs, 10 milligram nevirapine once daily. More than 2.5 kgs, it is 15 milligram, that is 1.5 ml once daily. And the children between 6 weeks to 6 months, you have to give 20 milligram. From 6 months to 9 months, 30 milligram, and more than 9 months, it is 40 milligram. And AZT prophylaxis also depends on the weight. Less than 2 kgs, 5 milligram, and 2 to 2.5 kgs, 10 milligram, and more than 2.5 kgs, 15 milligram. This is given us twice daily, and duration is 6 weeks. And if the high risk, then we can increase that to the 12 weeks. For older children, the dosage may be increased, calculated as a 4 milligram per kg per dose twice daily. So the duration for an infant with low risk, the duration is 6 weeks, regardless of feeding option. High risk, if breastfeeding, 12 weeks. If exclusive replacement feeding, 6 weeks. Immunization and vitamin A supplementation. This is our immunization, universal immunization chart. So this should be continued, and as per your local preferences. For example, in some endemic area, JE vaccines are given. It can be given safely because it's an inactivated vaccine. Now PCV is that is pneumococcal vaccine is introduced in many of the states and many of the districts. It needs to be given, and there are some modifications required. So these children are more susceptible to infection and more likely to develop serious complication. So there is an increased need for vaccination against all vaccine preventable diseases. We need to always keep in mind that live attenuated vaccines are contraindicated only in severely immunocompromised infants and children with HIV infection. All inactivated vaccines can be given safely. All recommended childhood immunization should be administered in HIV-exposed infants. So some of the things which you need to keep in mind is BCG, which is a live vaccine. If not given at birth, should be delayed until ART has been started and infant confirmed to be immunologically stable. Measles vaccine should not be given to severely immunocompromised HIV-infected infants, children, adolescent, and young adult. Additional dose may be administered receiving ART following immune reconstitution. And we all know that measles vaccine is given as given in a campaign mode in the school. So there will be a lot of queries to you what to do about these children because it is given in the school. So you need to look at their CD4 count and viral load and their clinical symptoms. If they are asymptomatic, they can be safely given MR vaccine even in the campaign mode. If they are symptomatic or if they have severe immunosuppression, CD4 count is less than 15% or less than 200, then we need to be we need to advise them not to take MR vaccine. We need to wait till their CD4 is reconstituted, their immunity is reconstituted, then we can give the MR vaccine. Similarly, rotavirus is recommended for HIV-exposed infant due to their vulnerability. But if there is severe immunodeficiency, you should not be giving this. Hepatitis B can be given, but there will be some issues of seroconversion. Maybe you can check the seroconversion rate, and the booster doses may be required. Vitamin A supplementation is not a vaccination, it's a supplementation. It should be given as per the national immunization schedule. It's a very important component of the national immunization schedule. So there are other vaccines which are available in the private setup. There may be some queries to you, so you need to know about this. Inactivated hepatitis A vaccine, inactivated influenza vaccine can be considered in some situations. Varicella is a live vaccine. If the child is asymptomatic and not immunocompromised, can be given. HIV, a single dose HIV is indicated in unimmunized child for aged more than 5 years of age. And meningococcal vaccine, when there is an endemic, epidemic, you can give. And now there is a human papilloma virus vaccine. This is advised in adolescent. Now probably this is going to be introduced in the national immunization schedule. The next component of care of these children is growth and development. We all know this Trivandrum developmental chart. We can use this developmental chart for assessing the development. This is available with your white cards also. So these are growth curve. You need to plot the weight of these children on these growth charts, blue for boys and pink for girls. And length or a height for these children should also be plotted on these growth curve. And weight for length of these children should be plotted on these charts. This will give us we can track their growth over a period of time. We need to see whether the curve is parallel to one of these curves. If they are parallel to these curves and within these curves, then you need not worry. If the curve is dipping down, or it is plateauing, or it is coming out of these two curve lines, then we have to be very careful. We need to, these are early indication of growth failure and nutritional failure. We need to address this problem as soon as possible. So plotting the curve will help us in identifying the growth flattering in these children. And the next component of these management is diagnosis. So early infant diagnosis of HIV-exposed infant, an infant who are sick with clinical features suggestive of HIV, but with unknown HIV exposure status. So we all know this complicated table. So all HIV-exposed infant are maybe referred by pediatrician. So you first look at the age of the child. If they are between 6 weeks to 6 months, then collect a DBS and send for PCR test. And if HIV-1 is detected, then you collect another sample, and then you do the another test. If HIV-1 is not detected, then it will go to the advisory 2. Or if the child age is more than 6 months, 6 months or more, then you do a rapid antibody test. If rapid antibody test with all three serological, all three tests are positive, then you do DNA PCR. If it's called TNA PCR nowadays. If all three tests are negative, you can just follow up these children. You should be closely monitored for growth, development, and appearance of any HIV infection. And you can repeat HIV-1 TNA PCR at any time if the child becomes symptomatic. So if the second test is also positive, you need to consider the HIV. These children are HIV infected. If the second test is negative, then it is a discard, and you have to do a tiebreaker test. And if the tiebreaker is positive, you can consider the child as HIV positive. If child tiebreaker is negative, you can consider the child as HIV negative. For these children, the universal advisory is counsel the mother to maintain strict adherence to ART, because maternal ART adherent ART is a significant risk reducing strategies for the transmission of mother to child HIV infection. Similarly, you have to initiate cotrimoxazole prophylaxis at 6 months of age continue till you reliably rule out HIV infection in these children. Continue babies on exclusive breastfeeding till 6 months and then add complementary feeding. For all babies on replacement feeding, continue the same and add complementary feeding at 6 months of life. Babies diagnosed with HIV positive to be linked to the ART center for ART initiation. In case of serodiscordance at 18 months, continue ART and follow the algorithm of management. So for children who are HIV positive, start co-triamoxazole prophylaxis if not already started. So exclusive breastfeeding should be continued, and if age more than 6 months, start complementary feeding. So these are different advisories. You can go through that. Suppose if the baby comes to you after 18 months of age, then what to do? You need to look at whether the baby has previously tested with PCR. If the child is tested, not tested with PCR, you have to do HIV antibody test with all 3 serological tests at ICTC. If they were previously detected, PCR was done, then also you have to do all 3 serological tests. So when you do all 3 serological tests in a child who is not previously tested for through PCR, if all 3 antibodies are reactive, then you consider this child as HIV infected and start the ART therapy. If antibody reactive on 2 tests or 1 test, this is indeterminate, you have to repeat antibody testing after 2 weeks. If all 3 tests are negative, you confirm you can confirm that HIV is negative in this child. If previously this child was tested on PCR and found and now you are testing these 3, and at that time child was positive and child was on ART also. Now you test with antibody test. If all 3 tests are positive, then you continue ART. If the test is negative in any one of them, there is a serodiscordant, then you have to do 4 tests. That is all 3 rapid tests: HIV-1 ELISA, qualitative HIV-1 TNA PCR, and quantitative HIV-1 PCR, that is viral load and Western blot. So if sample is reactive on any of the 5 tests, you continue ART. If non-reactive on all 5 tests, then you stop ART. Monthly clinical visit of the infant, close follow-up, monitor the infant for 6 months, conduct viral load every 3 months up to 6 months. If no, if the viral load, if you find any quantifiable viral load result during that time, you restart and continue ART. Otherwise, you can discontinue ART, but you need to continue to follow up these children. In some situations where nowadays the kits are not available to do DNA PCR, we are seeing a lot of symptomatic children. So in these children, presumptive diagnosis of HIV can be made. So HIV, if infant is, first you do a testing in the rapid test in the infant. If it is reactive, or the child, and plus child is also having WHO stage 4 disease, or child is having oral thrush, pneumonia, or severe sepsis, and there are no other factors which will which can explain these conditions, and mother is having very advanced disease with CD4, high CD4, and maternal ART, mother is died of HIV, or CD4 count in the child is less than 20%, then we can take them as presumptively severe HIV infection in the infants, and we can start treatment in these children also. Now, to summarize this, children more than 18 months are tested according to the national adult testing guidelines. So HIV infection, 2 positive in a clinically symptomatic children, even if 2 positive tests are there, antibody tester, you can take it as HIV infection, positive infection, and 3 in asymptomatic children, 3 tests should be positive to consider the child as positive. So for children less than 18 months, confirm PCR and check for breastfeeding status. For children more than 18 months, antibody testing. This is the summary of testing in children. Co-triamoxazole prophylaxis, start at 6 weeks of life, continue till their HIV is confirmed or ruled out. If it is confirmed, continue till 5 years. Uninfected, you can stop it at that time. So these are various follow-up protocols. So you do counseling for infant feeding every visit, growth monitoring, developmental assessment, immunization as per the schedule, clinical assessment, Testing is done at 6 weeks, 6 months, 12 months, and 18 months. Maternal HIV and ART adherence to be assessed at every visit. Now, the next important section is management of newly diagnosed HIV infection in children, including ART initiation. This is the very important component. Unfortunately, with all our measures, there will be some breakthrough infections in these children. In such children, what we have to do? So first step is you need to determine what is the clinical and immunological staging. So for that, you need to have a clinical assessment, growth assessment, developmental assessment, laboratory assessment, and psychological assessment. So you need to ask for 4 symptom screening for tuberculosis. In children, it is fever, cough, weight loss or poor weight gain, and history of contact with tuberculosis. And key age appropriate developmental milestones to be asked, behavioral abnormalities, relevant medical documents should be reviewed, and assess immunization status. And look for signs of anemia, edema, which can be due to your malnutrition, nutritional deficiency like rickets or some vitamin deficiency in the form of angular cheilitis, ball tongue, and jaundice. And you should look for fever, respiratory distress, decreased activity, and altered sensorium for OI, oral thrush, lingual erythema, and OHL, that is oral hairy leukoplakia, parotid enlargement, herpes, digital clubbing, and lymphadenopathy. These things will give the chronicity of the disease as well as help in staging clinical staging the child. HIV dermatitis and hepatosplenomegaly. So in the development, there are some indicators like loss of previously acquired developmental milestones, concerns about vision and hearing, persistently low muzzle tone or floppiness, even the other way around also increased tone, no speech by 18 months, and especially child is not communicating by any other means, no gestures, nothing. It can be an early signs of autism. Asymmetry of the movement or a hand preference. We don't expect you to know that the child is either a right-handed or a left-handed before 18 months. Any child you can, if mother says my child is a right-handed child or left-handed child before 18 months, then you need to be careful because the other side may be weak in that child. So then asymmetry of movement, persistent toe walking, head circumference plus, either large head or a small head. And if there are any concerns as a doctor you feel. And the good indicators like child is sitting by around 12 months of age, walking by around 18 months of age, there is no tiptoe walking, can able to hold the object by 5 months, reaching for the object. So if these are there, these are good signs. So you can use this Trivandrum developmental screening chart, which we have already discussed. So other lab parameters we need to do before we start ART is you need to do a complete hemogram, urine routine. These are routine things which should be done in your hospitals. RBS, urea creatinine, serum bilirubin, and SGOT, SGPT, VDRL in a young child, CD4 count and CD4 percentages, HPSAG and HCV. If available, chest X-ray. In an adolescent, first time you can do pregnancy test. In an endemic area or epidemic area, in an endemic area, you can do leishmaniasis. And some symptom directed, as per the physician choice, you can do investigation to rule out opportunistic infections, complete liver function test if there is a co-infection with hepatitis B or C, lipid profile if you're planning to start an PI-based antiretroviral regimen, and ultrasound for abdomen. If any of these tests are not available, you should not hold till these things are done to start ART. You can start ART whatever things are available, because delaying ART initiation is not advised. It can be detrimental for the child condition. And remember, CD4 is one thing which is supported by the NACO. Rest of the things are to be done with the help of the state health department, whatever is available in the hospital. So this is the classification based on the CD4 count and percentage classification, immunological classification. This is available in our guidelines. You can go through this. And pre-ART care. Now with test and treat strategy, there is nothing called as pre-ART duration. So, but the care is same during that time, though the period is short. So all the things which were relevant, which were doing earlier, we need to do that during this time before you start ART. So we have to manage some of the clinical situation like undiagnosed active infection with fever, tuberculosis, PCP pneumonia, fungal infections, pneumonia, malaria, all these things, and diarrhea, these things to be managed. If there is drug reactions, you need to treat that first. You need to wait till that drug reaction is subside, and then we need to start ART. If there is a non-severe pneumonia, then you need to try to find the reason for anemia, sorry, non-severe anemia, try to find the reason for anemia and try to avoid zidovudine in such situation. Skin conditions, suspected MAC or cryptosporidiosis or microsporidiosis, you need to start ART early. CMV, wait till induction phase for the treatment of CMV is done, and then you can start. Similarly, toxoplasma also, wait for 6 weeks, and then you can stabilize the patient, start ART. If there is severe acute malnutrition, stabilize the child of metabolic complication and sepsis, establish the F100 diet, usually by around 1 week, then you can start ART. Another important component is we are seeing now children coming late to the ART center when they are adolescent for the first time, or the children who are already on ART also, they are coming to you. So we need to evaluate these children, these adolescent with HIV. How do you evaluate? There is a step-by-step guidance and comprehensive assessment of HIV. You look at their home situation, where do they live and with whom do they live, any recent changes in their home situation, and what is their perception about their home situation. They're happy, not happy, there's something going on, any abuse is going on in the home, somebody else, not family members living with them. So we need to carefully ask them. Look at their education and employment, whether they are studying or working, how are they doing, how are their relationship with the teachers, employers, colleagues, what they do during their breaks, and what do they eat, what is their activity, are they abusing any drugs, tobacco, alcohol, any substance. Similarly, what is their sexuality, their knowledge about the sexual and reproductive health, do they have any question regarding this, are they active sexually, if yes, are they taking any steps to avoid sexual and reproductive health problem, their sexual orientation, their safety, and are there any red flag signs of mental health issues like suicide and depression. So we need to ask these things step by step guide. These are available in our guidelines. You can go through that. And once you assess these children, we need to start them on antiretroviral therapy. So the 3 steps are: confirm the HIV infection, treat and stabilize the acute condition and opportunistic infection, do a baseline CD4 count, then initiate appropriate ART. The guidelines is simple: less than 6 years, body weight less than 20 kgs, abacavir, lamivudine, and ritonavir boosted lopinavir. 6 to 10 years of age, body weight between 20 to 30 kgs. Instead of lopinavir, you can give dolutegravir. Children more than 10 years and body weight more than 30 kgs, TLD is the choice. So any infant or children initiated on any regimen must be based on the weight. And we have got dosing chart. You can go through that. Every visit, check for the body weight of the child, because these children are growing rapidly. Their weight will increase. So you have to augment their dosage based on their body weight. We have seen that many of times one of the important cause for treatment failure, especially early treatment failure, is inadequate dosage. They would have been started with some dosage and you would have continued with the same dosage in spite the child gaining a good amount of weight. So we had to be checking these body weight with every visit, and appropriate dose adjustment should be made. So these are various dosing schedule available. And now there the abacavir and lamivudine 120 and 60 milligram tablets are also available in the program, and the dosing charts are also been circulated. You can follow that. So in conditions where we are super boosting the lopinavir in situation like HIV-TB, so this is the dosing schedule there. We need to add extra ritonavir tablets. So choice of regimen, to summarize: 6 years, less than 6 years, less than 20 kgs, abacavir, lamivudine, and ritonavir boosted lopinavir. Children between 6 to 10 years, body weight between 20 to 30 kgs, abacavir, lamivudine, and dolutegravir. Children more than 10 years and more than 30 kgs, tenofovir, lamivudine, and dolutegravir. So in special situation like TB, so we had to make a modification of ART. If these children are dolutegravir based regimen, so use double dosage of DTG. If ritonavir boosted lopinavir based regimen, then super boost with ritonavir. Efavirenz-based regimen, no modification. If the children on DTG and LPVR regimen, combined regimen, then you have to do both, double the dosage of DTG as well as super boost the ritonavir. So in a CLHIV with co-infected TB, initiate ATT first, and as soon as possible within 2 weeks of initiation of TB, regardless of CD4 count, and you need to start ART. So among children with HIV and TB meningitis, ART should be delayed at least 4 weeks after treatment of TB meningitis is initiated. Otherwise, iris can happen, and corticosteroid should be used for meningitis. So here the regimen is, as we have already discussed, how to modify the regimen. And I think with this, I conclude my talk. The next RDLS will be on advanced disease management. This is on Tuesday, 21st of February.
Thank you
Any
so
questions?
much, sir. Thank you
I
so
would
much,
like to
sir, for the
answer.
informative session. And
Thank you.
sorry, we had to rush you through this lengthy session. Any questions from the participants? Please feel free to unmute your mic.
I don't think there are any questions.
Nothing in the chat
even
box.
in the chat
sir.
box.
Any questions from the participants? Please unmute your mic.
Hello, sir.
Yes, ma'am.
Ma'am, in case of infant prophylaxis for a baby who is high risk, previously NACO exposed as well as Zadodin exposed, madam. If the mother has been given single dose Nevirapine as well as ZL tablet, then hello,
Sir. Sanjeeva, sir.
I think if there are no questions, we'll wind up this session. Thank you very much.
So there's one question.
hello.
Yeah. Piyusha ma'am, please put your question in the chat box. I think there's some audio problem at sir's end.
Okay.
Sanjeeva, sir, there's one question in the chat box. I think there's some, yeah, sir.
Yeah, I mean, there is a question,
Right.
children less than 5 years is no LPVR is there. What is the alternate drug? I mean, I think this question will arise when the syrup lopinavir or a pellet lopinavir is not available for a very young child. I think by around 5 years, we should be able to give the tablets. If the pediatric tablet is not available, we can modify the adult tablet and give. But when there is no syrups are available or no pellet is available, then it will be very difficult. Probably we'll have to go back to Nevirapine, or we'll have to go back to efavirenz in a older children. And giving live vaccine when CD4 count is required. Yeah, you need to have keep an eye on CD4 count when you're considering giving a live vaccine. Your CD4 percentage should be more than 15%. Or more than 200, then you can safely more than 350. In fact, more than 350 can safely give live vaccines. Super boosting would be difficult as LPVR and RT are not available separately. I think these are programmatic issues. We can take it in a different form there. ARV prophylaxis for infant whose mother not on ART previously given single dose Nevirapine and ZL tablet for 7 days. I mean, I'm not getting this. What is this? ARV prophylaxis for infant whose mother not on ART previously given single dose Nevirapine and ZL tablet for 7 days. No, if the mother is not on ART previously, we have to give definitely as Nevirapine as well as Zidovudine. If mother, if
She is previously exposed to Nevirapine, sir.
not for 7 days. This is for, if mother is not on ART, then this will be high risk child. If exclusive breastfeeding is given, then we need to give for 12 weeks. If I'm getting the question correct.
Yes, sir. But if she is exposed previously to Nevirapine as well as Zadodin, then what will you double syrup? What will you say? Because we
Any
can't.
nevirapine or efavirenz? What
We
is
can't
that
give
question?
nevirapine, sir, because she is exposed to nevirapine.
ZL plus LPVR.
ZL plus LPVR. Okay.
No, I'm not. What is the question?
Hello, sir.
If no LPVR is there, what is the alternate drug?
Vinoda ma'am, can you please
Dr.
unmute?
Vinoda Bavdekar, I'm not getting your question. Can you please retype it?
Piyusha ma'am, is your question answered now?
Okay, ma'am. Not. We
I-
can't give nevirapine because already nevirapine exposed, and Zydovidin also we can't give. Only lopinavir, ritonavir, we have to give dual prophylaxis. So Zydovidin and lopinavir again we can give those two syrups. It's okay, ma'am.
So shall I repeat what she is asking the question?
It's okay.
Yeah,
ma'am.
please.
Yeah, like what ma'am is asking. So if mother is nevirapine exposed earlier, so we are giving dual dose, like Zidovudin as an alternative, we are giving the Zidovudin to the baby.
Okay.
Yeah, but now she is asking like nevirapine and also the mother is exposed to Zidovudin. So what
Okay.
is the regimen for the baby? Like what is the syrup?
So is the question clear now?
Hello, ma'am.
Yeah.
Are
Pallavi ma'am.
getting
Pallavi
Yes,
ma'am,
ma'am.
I have just texted my number in the chat box to Piyusha
Yeah.
ma'am. Please call me after the RDLS session. I'll pass on your question to sir.
Oh, okay,
Sure.
ma'am.
Right? Yeah.
Okay.
Vinoda ma'am. Sir, I don't think there are any more questions. Vinoda ma'am, please send your question to us and we'll pass it on to sir. So can we quickly run the feedback form, please?
Kiran, can we wind up?
Yes, sir. Yes, sir. We are just running the feedback form. Thank you so much, sir.
Eight-month child born to HIV mother with 100% adherence. At 8 months, she was positive in all serological tests but negative in DBS. Active child with good weight gain, and how to consider this child. Yeah, I mean, if you look at our EAD algorithm, any child after 6 months of life, we usually do the antibody test. And if antibody test is positive, then you do TNA PCR now. If TNA PCR is positive, you do one more TNA PCR and you consider the child as positive and you start treatment. If TNA PCR is negative, then you just follow up the child considering as HIV negative and you follow up the child. In this situation, I think this 3 serological antibody test could be false positive, maybe due to maternal antibody. It's still 8 months, though the chances of, though we say around 70 to 80% of the time, by around 9 months, maternal antibody disappear, but there is still around 10 to 15% of time the maternal antibody can persist. So we can still consider this child as probably uninfected. Since child is gaining good weight and doing otherwise fine, you can continue this child with co-triamoxal prophylaxis under close observation, and you can repeat the testing at 12 months and 18 months if the child doesn't become symptomatic before that.
So there's one more question in the chat box.
Yeah, mother on second line ERT with TL retinowir boosted atazanavir, and previously on ZLN as first line ERT. ARV prophylaxis for infant, viral load suppressed done at 6 months ANC. Okay, so here, I mean, it's a very difficult proposition. Since mother was already exposed to nevirapine, we can't use nevirapine here. Zidovudin, we actually, the chances of archiving the Zidovudin resistant viruses are difficult. I mean, are unusual. We can still consider Zidovudin and 15 days for 14 days initially Zidovudin alone, and then probably Zidovudin and Zidovudin plus retinowir boosted lopinavir from 14 days onwards. Ideally, this child should be receiving raltegravir. Unfortunately, it is not available in the program. Even in the private also, raltegravir syrups are not available. Ideal situation, raltegravir would have been better. But with the constraint of availability of drugs, the best regimen we can choose for this case would be Zidovudin initially, hoping that Zidovudin has not caused much damage to the resistant profile of the viruses, since the viral load is suppressed. And we have to take this chance and give Zidovudin, and 14 days later we can add retinowir boosted lopinavir. Negative or repeat DBS after 6 months for what? I don't know. What is the question?
Vinoda ma'am, please send your question to me. I'll pass it on to sir. Sir, we can conclude the session now. Kiran, can you please announce?
Sir, can we conclude the session now?
Kiran, I think there's some problem with sir's mic. Thank you to all the participants for patient listening. We'll conclude the session now. Thank you. Thank you, sir.